Are we good to go? Hi. Good morning, everyone. Thanks, Ritesh, for having me here. So, management of endophthalmitis revolves around good medical management as well as surgical intervention, and the primary aim being salvaging the eye as well as a good vision. So, the first insights were provided by endophthalmitis vitrectomy study, where they had concluded that early vitrectomy is useful only when the vision is light perception or less. And if the vision was hand movements are better, whether you go in early or late, it doesn't matter. But we must realize that this study was done in 1980s and 90s, when our surgical instrumentation was not that great, and there was various pitfalls. Nowadays, our management of endophthalmitis is determined not just by vision, but the clinical picture and the course and the severity of the disease. We normally go in for injections if we can see the retinal details. If the red glow is very good, then we go in for injections. But if there's a lot of exudates, the glow is very poor, or we can't see retina, we go in for early vitrectomy. So there's various studies done in Europe and US. CVS study is one which have shown great results post early vitrectomy in endophthalmitis. And as I said, there are various conditions where you want to go in early, like where the infection is very severe, you cannot see any retina, there's a lot of exudation in the retina, and bleb-associated endophthalmitis, suspected fungal or endophthalmitis with the intraocular foreign bodies. So all of us know why vitrectomy. Vitrectomy helps us get the vitreous samples in adequate quantity so that we can grow and culture and be specific with the antibiotics which we give. It clears the ocular media so that we can assess the retina, and we have better diffusion and penetration of various antibiotics which we put inside the eye. And besides that, all the toxins, endotoxins released by bacteria and other organisms get cleared off very quickly. So I think I'll go by video, and most of these cases they have membranes and hypopyon. It's always better to clear this membrane after securing the infusion cannula. And as in any other vitrectomy, it's at most to see the infusion cannula inside the vitreous cavity before going in, before starting the infusion cannula. And this is how we do it. If you can't see it in a handshake technique, go clear the exudates over the infusion cannula till you see it. You keep on cutting, and this is a high cut, very low suction. Once you see that shine, that means you are inside. Your infusion cannula is inside and you are safe. And this bubble, when it comes, it tells me that you are actually in the vitreous cavity. So once this is done, you can go on with your regular vitrectomy. Whether you go in for complete vitrectomy or core vitrectomy, that you can decide on the severity of the infection and other factors which we'll discuss. So I don't hesitate to scrape epithelium, because a lot of cases, infected cases, people say don't scrape the epithelium, you'll have a corneal infection also. But the thing is, if you can't see retina, you can't see vitreous cavity, your surgery is of no use anyways. So clearing the ocular media is of utmost importance, as we discussed earlier. And the way we take vitreous biopsy sample, earlier I used to start the infusion as soon as I start taking the vitreous biopsy. Nowadays, what I do is I attach syringe to the aspiration tube, and we cut. I'll just show the video there. You need undiluted sample. So this is dot cutter, and there's a connector in the aspiration tube. So this connector, you put a syringe on it, and once you are inside, you just cut, don't aspirate with high cut rate. And once you've started cutting, after a few seconds, you aspirate with the syringe slowly, so that you don't put a lot of traction on the vitreous and don't pull off the peripheral vitreous. The cutter is working, and my assistant is aspirating it slowly with the syringe. And then when you take it out, you can just bring the whole thing out and send the sample for the cultures. And as we see, these vitrectomies are from top to the bottom. You start from the IOL and then you go down, because you want to see, as you go down, you want to see the ocular structures. And I normally, the norm was core vitrectomy, where you go in, you create some space so that you just push the antibiotics whether you see anything or not. This is what the classical teaching was. But nowadays we keep on doing the vitrectomy till we think it is safe. Whether to induce the PVD or not, that is very controversial. If you don't see any necrotic retina, you don't see any bleeders in the retina, PVD can be induced. But most of us, we leave attached vitreous behind if the PVD is already not there. And inducing PVD, because most of these cases they get ERMs later on anyways, so you have to go in most of the times again. So we don't push too much for PVD induction. We just clear the vitreous cavity, clear as much as vitreous possible, especially in the center. Don't go much towards the periphery in the fear of creating inadvertent breaks. And another question is whether to explant the IOL or not. Most of the cases we want to preserve the intraocular lenses, and except for fungal endophthalmitis and P. acnes endophthalmitis, the advantage of removing the IOL is that you get a single cavity. You can inject and the antibiotics, they diffused into the anterior chamber as well as posterior chamber equally. And this is mostly in severe cases, and especially with fungal and P. acnes endophthalmitis. Traditionally, we were taught not to put silicone oil, but it is not necessary in all the cases. But wherever you find breaks or suspected breaks in the retina, that is the time we push silicone oil. The only important thing you have to realize is you should have, if possible, done a PVD. Although I've seen cases where we have put oil without inducing the PVD also, because later on you can tackle with the retina. But yes, if it's better to do the PVD and put the oil. The oil has another advantage, that it is bacteriostatic. So it helps in slowing down the growth of microorganisms. And the caution is you have to reduce the dose of the antibiotics which you are pushing inside the eye. Thanks for your kind attention. Thanks.
Thank you, Dr. Rajeev. That was quite a comprehensive discussion on endovitrectomy. We have comments, so I think time for 1 or 2 comments, Dr. Rajeev.
Nice videos with extensive vitrectomy. As you mentioned, I agree. We need to be very cautious in peripheral vitrectomy. Although we are doing more vitrectomy than what we were doing earlier, including hyaloid separation from the retina. But periphery, you need to be careful, because if you create a break, then it's like almost losing that eye. So the idea is not to remove the entire vitreous and like any other VR surgery. But yeah, as long as you can do a safe vitrectomy, more than just a simple core vitrectomy, which is possible nowadays, we go ahead and do. Yeah.
One additional point, when you were doing that anterior chamber manipulation to take out that membrane and putting your infusion cannula, rightly said that we need to visualize the tip of the cannula before we are switching it on. I very often start off with an AC maintainer or an infusion in the anterior chamber, and till a certain amount of my actually anterior vitrectomy is also done, and beyond that only I try and then shift to a posterior infusion. I generally don't even try and put it before that. So that's one difference which I generally do that.
I have a question. Do you have access to a 6 mm cannula now?
Yes, we have that old sutured cannula is there, but then with these 23 and 25 gauge, the cannulas are already too long.
No, but they stopped manufacturing 6 mm, at least Alcon. It's not available in the market, so I just want.
No, we have it. I can give you one if you want.
Sure, we're desperate for one.
Only I want to ask Nayan, do you still follow that Venco Kefta, or you've switched to Venco
Imipinum? We switched to Imipinum long time ago, but our recent data shows that in the endophthalmitis management study, or EMS, almost 60% of the GNB are, I would say it's only 60% sensitivity to Imipinum also. Forget about Cefta. When Cefta came down, 60%, that means 40% resistant. Now imipenem also, it's only 60% sensitivity, whereas colistin is about 98% sensitivity is there. So we are giving imipenem, but at least in Vizag, Avinash is more in favor of colistin in the first instance itself.
So Venco plus colistin or Venco plus imipenem.
Imipenem or at least colistin, but not ceftazis. Yeah.
Okay. Because the message is still, a lot of people still struggling with finding the right antibiotic for gram-negative bacilli, because these are the ones, if you get Pseudomonas.
Yeah, so ultimately it's from your own profile that you also have to look at. But our data, our organisms are quite resistant to imipenem.
Also, you have to look at the antibiotic susceptibility patterns. They keep on evolving over
Yes.
time. Earlier we had Cefta, then imipenem, now colistin. Sometimes you can also make a decision on the basis of a clinical judgment as to the presentation. If there is extensive corneal melting, ring infiltrate,
Yes.
clear melting is already started, makes sense for you to go with Venco plus imipenem. You are probably just seeing clinical infiltration or just mild endophthalmitis to exaggerate. Probably you can still try Venco Cefta. But if you see those ring infiltrate, extensive corneal melting, corneal involvement, then
Yes.
it probably would be a judgment call to jump to rather directly.
No, the decision here is clinically whether it's GPC or
Yes.
GNB.
So which shifted
But
to
if you have clinical suspicion of gram negative itself, the question is whether it's ceftaz, imipenem or colistin.
Then probably can shift to, I mean, get you then for clarity of
yes.
what
So we shifted from Venco plus Kefta to Venco plus Tazak, then instead of Tazak now imipenem. That's what I follow. Venco plus imipenem in the first go.
You
And-
don't have time actually in terms of the severity. You can't
Yes.
tell, wait for another 2-3 days
Yes.
and the results come. And
So in RPC, I know they are using piperacillin and tazobactam as
Yes.
the moment they suspect GNB, their first line is piperacillin.
Because the message, the wide message to everyone, even our anti-segment colleagues who actually inject sometimes, because we tell them inject and then send. अगर 1-2 दिन लगेंगे तो they still Venco and Kefta. They still stick. I think we need to
that
change
we need to advise them.
Yes.
And,
Thank you.
Thanks a lot, Dr.